Hi, I'm Ruben Webby. I'll be presenting a fictional case study of Sebastian Jensen, a teenager who has been diagnosed with osteogenic sarcoma or osteosarcoma. I will examine the etiology, tumorigenesis, pathology, and clinical manifestations of osteosarcoma. Sebastian is a 172 centimetre tall, 17-year-old distance runner from Bendigo, Victoria. He's currently running 60 kilometres per week and competing at a state level in cross country next month. Over the past 6 months, he's reported intermittent lower limb soreness after activity, which he has attributed to training stress or an Osgood-Schlatter's flare-up after he had it at 12. His training load, injury history, and age is an important context as it influences symptom perception and diagnostic delay. Sebastian had Osgood-Schlatter disease at the age of 12 at his right proximal tibia, caused by strain at the patellar tendon insertion. It self-resolved within 2 months, but left a persistent prominence on his tibial tubercle at the right knee. He has no history of pathological fractures, systemic illness, or chronic disease, and there are no known major risks in his immediate family of hereditary disease. He continues to train with minimal modification despite some discomfort as he hopes to compete in state cross-country championships next month. Over the past 2 weeks, Sebastian has begun to have localized edema, a tender lump, and more persistent pain at his right knee, which leaves him waking up at night, having an altered gait, limping, unable to use full range of motion, and having to miss training sessions, as he has begun to get pain at rest as well. The clinical red flag was pains at night which would wake him up. He was taken to a doctor and referred for an MRI and X-ray. The findings meant Sebastian was subsequently diagnosed with osteosarcoma of the right proximal tibia. Osteosarcoma is a primary malignant bone tumor characterized by malignant osteoblastic cells producing immature osteoid matrix. The etiology of osteosarcoma involves epidemiologic and environmental factors, as well as more rarely genetic inheritance in about 4% of cases. Osteosarcoma is most common in those that are tall for their age. There is also a 3:2 ratio of males to females. While Sebastian falls outside the expected epidemiological profile for osteosarcoma, he is at risk due to being in late adolescence, a period of increased osteoblastic proliferation which increases probability of mutations within the osteoids. Genetic risk factors include Lee-Fraumeni syndrome, which gives predisposition to mutation of the TP53 tumor suppressor gene. Inheritance of Rothman-Thompson syndrome can also contribute. It is an autosomal recessive disorder characterized by mutation in the REC-QL4 gene. Alternatively, hereditary retinoblastoma, mutation of the retinoblastoma gene RB1 on chromosome 13q14, can also contribute. Hereditary disposition is scarce, as mentioned it makes up 4% of cases. Due to the lack of cancer in Sebastian's maternal side of the family, he may have inherited a mutation from his father's side of the family, as little information is known. Sebastian's prior diagnosis of Osgood-Schlatter disease does not have anything to do with the etiology of osteosarcoma, but the anatomical position and pre-existing pain that he experienced as a 12-year-old contributed to delayed recognition of symptoms. His history as an endurance runner also has no link to his osteosarcoma risk, but did contribute to a diagnostic delay. Osteosarcoma is a malignant mesenchymal neoplasm characterized by production of an immature osteoid matrix by malignant osteoblastic cells. In osteosarcoma, mutations involving the TP53 or RB1 genes, or, alternatively, amplification of the MDM2 gene, cause these processes to proliferate. The TP53 gene typically encodes the p53 protein, which induces cell cycle arrest, activates DNA repair synthesis, or initiates cell apoptosis if the damage is irreparable. In osteosarcoma, mutations or dysfunction within these tumor suppressor pathways impair the cell cycle control. Consequently, abnormal osteoblastic precursor cells are able to continue proliferating instead of undergoing apoptosis as they typically would. The malignant tissue progressively expands within the metaphyseal region of the proximal tibia, infiltrating the medullary cavity and disrupting the architecture of the tibiofemoral joint. The histopathological image shown on the left demonstrates the microscopic malignant osteoblastic cells in the middle and the top, with non-malignant bone at the bottom of the image. In Sebastian's case, rapid skeletal growth undergone throughout puberty and late adolescence increased osteoblastic activity in the metaphyseal region of the proximal tibia, creating greater opportunity for replication errors and malignant transformation, as seen in his case. Rapid neoblastic proliferation in the region produces persistent bone pain, progressively becomes non-activity dependent, and begins to persist at rest and night. Periosteal elevation and soft tissue invasion produce edema and tenderness around the proximal tibia, while cortical destruction impaired structural integrity and contributed to altered gait mechanics and reduced athletic performance. Because Sebastian already had a prominent tibial tubercle, these pathological changes were initially misinterpreted as benign training-related inflammation rather than malignant progression of osteosarcoma. In conclusion, Sebastian's current running load and prior Osgood-Schlatter disease diagnosis obviously did not contribute to the tumorigenesis of the malignant cells, but they did contribute greatly to delayed clinical recognition by mimicking the early symptoms, causing diagnostic disambiguity, and preventing Sebastian from seeking medical assistance earlier out of fear of missing state championships in cross-country as they are fast approaching. The pathological processes related to the proliferation of malignant cancer cells directly explain his worsening pain over time, gait alteration, and reduced athletic performance. Ultimately, this case reinforces the importance of maintaining clinical suspicion when adolescent athletes present with persistent and non-mechanical pain, particularly when symptoms deviate from that expected of overuse injuries. Thank you very much for watching. I've been Ruben Webby, and these are my references that I've used throughout the research for this project.